You got this in your handout, this Visitation with Infants and Toddlers in Foster Care. The data I'm going to talk about now comes from this a little bit, but want to reference that for you. Just to prove that this infant mental health stuff is real, here is a whole manual, Handbook of Infant Mental Health. It's got some really good stuff in it. I'll pass that around and let you take a peek at it. This book, The Boy Who Was Raised as a Dog, and Other Stories from a Child Psychiatrist's Notebook. Bruce Perry is a neuroscientist, child psychiatrist, who works exclusively with child trauma. And these are vignette stories about his work over the last 15 to 20 years, and they're excellent. I think it ought to be mandatory reading for anybody that works with kids. But they're horrendous stories, but they illustrate examples of things that can be done, and improving, and it outlines the model of what we're trying to talk about. There's pockets of different things happening all over the country, and it's amazing to me how even though they're different people, there's a lot of similarities happening, and this illustrates a lot of that. The Boy Who Was Raised by a Dog. It's coming around. Some of you early childhood people, if you haven't seen this one, that's really good. But even some of the rest of you, it's Rethinking the Brain, and it's very readable information about brain research and early childhood and infant toddler development. And you all got this wheel in your folder, and it really is very excellent. I'm glad that these got put in your folder today. But if you spend a little time looking at it, there's just lots and lots of good stuff on there. Any comments about what we've done so far this morning? Yes? The question was, do families that take children under 3 get specialized training? And yes and no. Some will and some won't. Yeah. This piece is the parent time piece, to get us thinking a little bit about, so when the kids are taken out of the home, how do we maintain this attachment process? Or how do we improve that attachment process? We know that they may not have the best attachments, but are there things then that we can do to build the relationship? Because the best place is to try and build the family to make it work. During the first few months of life, babies begin to show marked preference for 1 or 2 caregivers. By 4 months, babies communicate that preference through, following their caregiver around, showing preferences for certain people, smiling, quieting for someone more than others. The last baby encounter I had was must have been Sunday afternoon. And I needed my neighbor to come help me on a project I was working on, and he had his Nicholas with him. And Jim needed to do something, and so he handed Nicholas to me. I've never held Nicholas. This is the closest I've ever been to him. Nicholas is, 9-10 months. So what do we know about Nicholas right now?
He doesn't want you.
I was the last person he wanted. And Jim says, God, he's never done this before. I'm thinking, oh yeah, great. I'm going to think I pinched him or something, an abusive neighbor. But as I was thinking about this stuff, I thought, well, of course he didn't want me. I want Dad, even though Dad's right here. It wasn't enough. What did he need? He needed to be touched. He needed to be held. He needed to be soothed. 7 to 14 months, that attachment has intensified. And when separated from the primary caregivers, babies often cry or protest. Just what I was talking about. And Jim's within 3 feet of us. And then this is important because even when they're reunited, they may initially protest or avoid the caregiver. Now, that's not to be misinterpreted as poor attachment. It's normal. The kid's pissed. But then over a few minutes, 15 minutes, you get that dance and they're okay again. And they feel reconnected. By age 3, children begin to generalize attachment to other people. They feel more secure with other relatives, significant neighbors. I'm going to take you on a brief aside because there was some research done in the 80s, and the program is called Developing Capable People. Some of you will remember that. And they looked at, okay, so what's the thing with these baby boomers? Why, beginning in the 60s, did we have increased suicide rates and, all this stuff? And when they started walking this back, what they discovered was that when the baby boomers, the first group, hit kindergarten, you know what happened that day? Class sizes tripled and doubled because nobody saw it coming. So that was one factor. The other factor which was huge was what Japan did over 1,000, 1,500, 2,000 years, what Europe did over 700 years, which was move from rural to urban, the United States did in 40 years. Moving from agrarian to urban, people moving around, becoming increasingly mobile. And one of the implications of that was we now had people raising kids in an absence of networks. So prior to that, if Sarah's the mom, but she's not real with it today, Aunt Mary's right here who's going to pull up the slack for her. And Uncle Bob is right around the corner. And so everybody's helping everybody out. And so mom isn't isolated to be left alone. And so you have this built-in wraparound stuff. Now we give it fancy names, try and spend lots of money, and call it therapeutic intervention. So part of what we're dealing with is there are cultural changes that we need to understand. Attachment relationships are one of the primary goals of infancy, if not the primary goal of infancy. Secure and stable attachments are the foundation for social, emotional, and cognitive development. You've heard me yap about that now for 2 hours. Later in life, securely attached children have greater capacity for self-regulation, effective social interactions, self-reliance, and adaptive coping. Even children with secure attachments can be harmed by the loss or disruption of a primary relationship. When you study trauma, Perry, Peter Levine, a lot of these folks will talk about just childhood events can be traumatic. Kids having to be in a hospital, having a parent killed tragically. Those things are traumatic and they have a sudden disruption of that attachment relationship. I think it was in Perry's book I was reading, he was telling this story about this kid who got sick with some kind of skin disorder. And this must have been in the 40s or 50s. But the kid was put in isolation for 7 days with no contact from his family. And as they walked this back, kind of doing a case analysis of this kid, what they discovered was he was completely different after that. He was angry, he was isolative, he couldn't relate to people. And then you go on to read this vignette, and it's the Unabomber. It's Ted Baczynski. If you're into this kind of thing, there's a book called High Risk Children Without a Conscience. And it talks about the effects of trauma, neglect, and abuse on children. And because there is a correlation between attachment problems, attachment disorders, those are the kids that grow up to be conduct disorders, antisocial personality disorders. And so when you look at some of our most severe folks who have the most severe problems, they have had these early childhood tragedies. Children grieve the loss of their contact with their parents. They grieve the loss, even if it's chaotic, it was what they knew, and so that's a loss. Now that seems totally bizarre, but it's a change. It's a loss for them. It's the only parent and situation the kids have known. Separation evokes strong and painful emotions. The removal of young children begs the need for frequent and consistent contact with their parents. Traditional brief weekly encounters aren't enough. We've talked about how do you maintain, how do you develop attachment. It's it's a way of life. A young child's trust, love, and identification is based on uninterrupted day-to-day relationships. Need to be frequent and long enough to enhance the parent-child relationship. Benefits of frequent visitation: promotes healthy attachment and reduces the negative effects of separation for the child and for the parents. It establishes and strengthens the parent-child relationship. It eases the pain of separation and loss for the child and the parent. Keeps hope alive for the parents. You know, it's reciprocal. If they feel hopeless, they're going to be less likely and motivated to try and do the things they need to do. It involves parents in their child's everyday activities and keeps them involved in their development. It helps parents gain confidence in their ability to care for their child and allows parents to learn and practice new skills. Provides a setting for caseworker or parent to coach and suggest how to improve parent-child interactions. You know, typically what happens is we have a supervised visit and the person is not a coach. They're directed to just be there. And that isn't enough. It isn't enough. We need to allow foster parents to support birth parents and model positive parenting skills. There's a movement nationally to have visits of young children happen in foster homes. Now, I think you'd have to have all the right conditions and set to make that work, but the research has shown some nice things with that. It provides the court information on the family's progress or lack of progress towards their goals. Facilitates family assessments and can help the court determine whether reunification is the best option for the child. And it helps with the transition to reunification. Visitation's at the heart of permanency planning, and a key strategy for reunifying families is achieving that and achieving permanency. It's designed to strengthen the parent-child relationship and attachment and reduce the potential damaging effects of removing the kids and the separation. You know, we've said this, but we'll say it again. The kids often come from a situation where it's not a healthy attachment. The stat was 82%, which is really, really high. And so we know that these kids are all at risk. And so when we remove them, we need to be thinking, how can I help bridge their path to a better relationship? So visitation isn't visitation, it's planned therapeutic intervention. But yet in how many of our cases, I mean, we have limited resources out here. I feel frustrated. There's only so much of me to go around and my colleagues to go around to make this kind of thing happen. And I think we're still in our infancy of really getting, what do you do with an 18-month-old? The best possible opportunity to heal damaged or troubled relationships, real-life opportunity to view parental capacity, provide the court critical information about the parent-child relationship. You know, I feel a little squirming in the room, and I think that's appropriate for all of us, myself included, because we're talking about cutting-edge stuff. And when you're talking about cutting-edge stuff, you get hurt, and you ruffle feathers, and we think, well, there's not enough money, and there's not enough this, and yet we really don't have any choice. We have to figure out better ways to do this stuff and challenge ourselves. Frequent visits allow parents to show their motivation to get their kids back. They provide evidence when a parent is not making progress towards their case goals, like not showing up for visits or not being consistent. You know, nothing chaps me more than when I hear about kids who have traveled to see their parents and then the parent doesn't show up. You know, what does that say to the kid? You're not important, we don't care about you. But on the other side, what have we done to help ensure that that happens, to help the parent? All helpful information to decide more efficiently about an alternative permanency plan. And Judge Johnson's going to talk more about that. Promotion of successful visits. You know, we're all responsible and accountable. Infant mental health is not about the psychologist or the therapist. Infant-toddler mental health is about all of us. You know, when we first started talking about some of this stuff, the occupational therapists and the physical therapists would say to me, I don't do that stuff. And I say, well, do you tune in to how the mom interacts with the child? And do you coach the mom about how to play with them and, to get them to be down on the floor with them and do all of those things? Yeah. I said, that's infant-toddler mental health. I said, does it make you squirm when the mom ignores the child when their needs aren't being met? Yeah. I said, that's infant-toddler mental health. Nobody has the corner on the market for this stuff. It takes all of us. Visits must meet the attachment and connectedness needs of children and their families. Support parenting and support case decision. We have to ensure that visits are in the child's best interest, and visits are conditional rights of parents and children. Unless there's substantial evidence to believe that visitation or supervised visitation would place the child's life, health, or safety at risk, then they should have those visits. This stuff gets real icky for me because sometimes I have to consult with other therapists and make my own recommendations about, the visit should stop. And from a psychological perspective, that's a tough one because a lot of the damage is hearsay or it's based on children's behaviors. But one of the things that we know about trauma is if you have been my perpetrator, even though nobody knows it, when I see you, I'll probably be happy to see you, but there's a good chance later that my behaviors will become extreme. Now, some of that we know is predictable. Kids, when they see their parents, they don't want to be separated again from them. They're angry and they're agitated and they're upset. But when I have a kid who goes back and he's twisting his penis with him, pinching it till he gets blood blisters, that's a little more intense than what we see normal children do when they're separated again from their parents. And I hate this stuff. I'm going to start working with adults again, I think. No, okay, it's no bad. I know it's not. It's just icky, and we need to acknowledge how icky it is because I need about 3 weeks off because I'm just tired again. But I know that opportunities like this, they should energize us a little bit and give us hope about what we do. Ensure the placement decision supports frequent, meaningful visits. Young children should be placed close to their parents. Tired infants do not make for effective visits. Foster parents need to understand the importance of visits and be supportive of such. I love foster parents. They are great, wonderful people. They're out to save the world, and sometimes they misunderstand their role, and I think that happens because we don't do a good job of reminding them of what their role is. Because they want to take every kid into their home. But on the front end of that, their job is to get the kid back and to support them. Sorry, I hope I'm not offending any foster parents, but you know that if you're in here. And then I mentioned that before. I haven't seen the studies or the stats, but there is this movement to have visits of young children happen in the foster home. Promotion of successful visits. If the child is placed in a kinship home, we need to do a better job of training them, too, to support the family, not just assume that it's going to go okay. The caregiver must be willing to support the formal visitation plan. Just some key points. There's a need for careful and ongoing assessment of the parent's ability to care for and interact appropriately with the child. My own belief is if there's certain risk factors, if there's violence, depending on the level of abuse, and yet we don't know exactly what's going on, that's when we need to formalize, assess the kids, assess the parents, watch them interact with each other, and that data then sets the stage for the next year. But it sets it up so we're either going to help them be successive or we know that they can't do it. And we've done it in such a way that we have the data that we feel okay about saying they can't do it. We're going to move for termination. And it's hard to repeal that decision because you've got such good data to support what's happened. This is really important. If a kid's been removed and they're little, they need to see that parent as soon as possible. Because when kids are removed, they think it's their fault. They don't know what's happened. Kids are egocentric. When kids have been abused, it's my fault. I shouldn't have told. And when parents do the visits, they should be responsible for the care of the child as much as appropriate. And these are all things we know about where visits can happen and how they can happen, but it's important to think about how, if we're going to make them happen more often, how are we going to be able to do that in creative ways? Can they go to the daycare? Who can supervise? Who can be a coach? Who's appropriate? Does a therapist need to be involved in all of those kinds of things? And this is really about a 3-day workshop we're jamming into a day. This chart is in that document, and this is just some ideas to suggest to get parents, effective parents do this stuff naturally. Infancy, develop the primary goal, one goal might be develop primary attachment. Well, you do that by meeting basic needs. You hold them, you change them. When a child is hungry, they get stressed. And you feed them, that reduces the stress. That's a bonding and attachment interaction. Bonding happens through stress and stress reduction repeatedly over time. So when the child gets stressed and they don't get that need met, the attachment doesn't happen.